I have to say thank you again to both Dr. Pelosi for having me here and for giving me the opportunity to once again talk about something that may be laughable. Maybe you can laugh about it and say that we are killing some Petro's law or someone's, but we're in the non-ablative treatment of vagina, and we hear Dr. Moore talking about thermal effect. We heard a lot about ablative modes in micro-ablative modes with the CO2 lasers. And what we are trying to do is thermal effect to make more collagen. How you get there is different ways, different equipments, different technologies, but as we come today, we see that we have over 60, 70, 80% chance to cure one person without taking her to the OR. And that's very good, because if that is my family, my mother, my aunt, I would rather do this technology, non-invasive treatments before taking her to the OR. So we stand in a moment that after many years of doing laser treatments for the vaginal tightness, and we see that some vaginal relaxation syndrome can be helped with this vaginal tightening, and some minor SUI, stress urinary incontinence, can be repaired with that. But you can do it with K-jobs, as simple as that. But what happened with mild SUI? I was like 2 years talking about incontinence, and my good friend Elias, he started a very good paper and research, you know, getting the objective side of this. So sad, Dr. Willie, he left. I really wanted to hear this. And talking about the stress urinary incontinence, but well, we have to say that it's just if a leaks occur during an effort, that's what you call an SUI, and we can talk numbers. About 30% will be more than 60 years old, and that increase with age. In Norway, more than 25% of the incontinence women were over 20 years. In European study, they say that over this almost 17,000 women, 30% of the 18 years have SUI, and the prevalence is between 23 and 44% of the SUI or some kind of urinary incontinence. So the SUI was the most frequent one. When we talk about this, we need to talk about fascia, muscles, endopelvics, contraction of the detrusor, ligaments, the support, but what we're talking here is the esfínter. And what we need to do, you need resistance in the uretral, trophism, and closure pressure. That's how you make this. And if we go back, really back in 1983, where this was published, say that Green proposed that the classification must be according to the measure of the anterior or posterior angle, and we say that SUI is a loss of the posterior angle of this. So what we have to say about that? We need, in 1981, my wires analyzed that the causes of surgical failure most with the deficiency of the mechanism of the esfínter. So if we get these three types of incontinence, we can see that the third type, or type 3, it will be intrinsic urethral insufficiency with leak point pressure fewer than 60 centimeters of the water. So now we know when we're talking about intrinsic esfínter deficiency, and for this ICD-9, Do the intrinsic esfínter damage, in which the urethra is usually well supported, but there are further rotations with the opening of the bladder neck and posterior urethra during the stress. So the sphincter doesn't close that very good. So what do we do? Do we do aerodynamics for diagnostic of this? Well, we might get the BLPP, that is a body leak point of pressure, and is that the smallest value of intravesical pressure, intentionally increased with the maneuvers of Valsalva. So when it makes an effort, we'll see what's the lowest point to get a leakage. And we take the MUCP, that's the maximum urethral closure pressure. That is just the maximum difference between uretral and the bladder pressure. So what can we define with the aerodynamics? One, that the BLP will be lower than 60, and the uretral will be lower than 20. That will give you an estimate that the patient has with the SISD. But in this article of 1996, with 84 women with aerodynamics and erythrocystoscopy, and with the diagnostic of SID, the sensitivity was very, very down, and the positive value of it was down. So what do? We do cystoscopy. Maybe we can do cystoscopy, but if the patient had hypermobility in the urethra, it's not a really good method of diagnostic. So for now, we can say that maybe all of the women who has SUI has some kind of defect in the sphincter. For that, we are doing some new treatment. We're doing laser in the urethra. And what we want to do with the laser, we just want to do light. That light, it will be converted in energy. That energy will be absorbed by the water, and that will give you a photothermal effect that is made by the laser, and that will help first contract the collagen if you want to tighten. But if you want to enhance the metabolism of and the tropism of the epithelium of the urethra, that's what you want to do. You want to do control heat damage and go. This is Gaspar slide from before to after, and you can see a lot of new vascularization and better epithelium. So we have an urethral handpiece. It's a small linear strong 8 French rigid space with 2 different kind of lenses, where the handpiece will go from 18 millimeters to 2 millimeters, and what we're going to do is we're going to pass this cannula through the urethra until the bladder neck, and we will do some non-ablative laser treatment. So we're going to deposit heat so we can help the tropism of the urethra. That will help to lower the diameter of the lumen of the urethra, and that will help the sphincter. So what we do with an ablative laser, how can we convert it to a non-ablative? We do small shots, pulses, very cold, one after another. So they will push on the heat until to the thermal, to the dermis, so where you want to get the heat going on. They say that the considerations for modern management of the stress urinary incontinence, evidence level 1B and a grade of proof for A, they say is MUC on lower than 20 and 60. And now they are changing the MUC to 20 to 35 because they don't have these predictive values so high. So what Dr. Adrian, that he's the first and he's the pioneer on this, he took 22 patients with type 3 SUI and with the ISD incontinence. And he said that after 2 treatments with an interval of 20 days, he will cure almost 40 out of 22, 14 of them, and with no results in 4 of them. And he was based on the ICQ and 1 hour pad test. I was looking at this and I started saying, okay, well, we have to try this, we have to see how this is working. So my protocol for this new way of being more objective will be to get 3 initial sessions and 1 extra session every 6 months. I will do follow-ups with the ICQSF. I will do aerodynamics prior and 1 month after the final session. This is because Elias suggested that this has to be done. And we're doing video cystoscopy to do the measures before and after. So before, this was the 3 patients that we have so far because we want to get type 3. No POP, no prolapse, nothing like that, just type 3, no movement of the urethra, and that, friends, is difficult to find, you know. And that's how can we get a really good sample, and we get lower 60 and between 30 and 20, lower than 25. So, and what we know that we have with the treatment, we have a really big lumen of the urethra. Afterwards, because when Dr. Pelosi told me that I can introduce this, I just got 1 aerodynamics before the Christmas hit Venezuela and the elections and everything that you hear. So Venezuela was stopped from November. So I just got 1 aerodynamics for her from one of my patients, and you can see the improvements. And what we're expecting with the cystoscopy is to get that lumen closed. So what are the changes in the aerodynamics before and after? You can see for this kind of type 3, we almost take it to type 2, maybe type 1. So these are 3 treatments, 21 days after, and this aerodynamics is 1 month after. When we start talking about the ICQCF and quality of life, this was the first session, second session, and third session before they were with the laser, and the improvement was more for ICQSF is an objective, but it's so subjective, you know, like it's 3 questions and it can be very subjective, but 80% of cure is a really good thing. And we can see the changes with the ICQ from the first session to the second session, how almost got cut in half and cut in a third. And that's a really good thing when you ask the patient that they were supposed to, you know, smile and they pee themselves, you know, because that's type 3. You gotta almost continuously, which out of nothing, no stress, just sitting there, smiling and peeing. So for them, just to get a little bit drier, that will be so subjective that they are cured. That's why 88%. But we will see with the follow-ups of these kind of studies that we can be objective and see how much improvement do we have. Can we make intrauretral with intravaginal? That will be later, but I think that they can be collided almost with the O shot over and with the other hormone therapy. Everything that you add to the patient, it will be improving the quality of life. So for now, we have a non-ablative laser who is doing some thermal improvement of the tropism, as they do in vaginal syndrome, of menopausal vaginal syndrome. And what we can say from the early OA, vaginal tension and uretral closure mechanism, uretral esfínter, are both very important in continence, and both are affected by low levels of estrogen after the menopause. So what are we going to do with those patients that cannot have estrogens? A lot of my colleagues will talk about that and have been talking about that. And what my colleague Gaspar say in the ICS when he presented this paper, he's concluding that also, although in this phase of one study with small number of patients and short follow-up, this non-ablative erbium jack laser procedure seems to be safe and efficiency alternative for patients with type 3 SUI. Nevertheless, more controlled studies should be performed to confirm this data. That's why I am trying to be more objective with Gaspar's paper. So I'm trying to get more objective, and it's hard to get patients. 14 minutes, I did it right?
All right.
Thank you so much.
Thank you.